You look at your face in the mirror every single day, so you would think you know it pretty well, right? But what most people do not realize is that Sjögren's syndrome, one of the most underdiagnosed autoimmune conditions on the planet, leaves visible clues on your face long before most people ever get a diagnosis. And not subtle clues either. Visible ones. The kind a specialist would recognize within the first few minutes of an appointment. The kind that have been there for months or even years before anyone connected them to an immune system that has been quietly attacking the body from the inside. Sjögren's is a chronic systemic autoimmune disease in which the immune system mistakenly targets and destroys the body's own moisture-producing glands, primarily the lacrimal glands responsible for tear production and the salivary glands responsible for producing saliva, though the disease does not stop there. It can affect virtually every organ system in the body, including the joints, the peripheral nervous system, the kidneys, the lungs, the skin, the blood vessels, and the gastrointestinal tract. It is classified in two forms. Primary Sjögren's occurs on its own. Secondary Sjögren's occurs alongside another autoimmune condition such as rheumatoid arthritis, lupus, or systemic sclerosis. According to the Sjögren's Foundation, the condition affects an estimated 4 million people in the United States alone, and it is believed to be one of the most prevalent autoimmune diseases in the world, though because it mimics so many other conditions, its true prevalence is likely significantly higher than current estimates reflect. Approximately 90% of diagnosed patients are women, with the condition most commonly presenting in the 4th and 5th decades of life, though it can and does occur in men, in younger adults, and in children. The average time between the onset of symptoms and receiving a confirmed diagnosis currently sits between 2.5 and nearly 3 years, with many patients reporting diagnostic journeys of 5, 7, or even more than 10 years before a rheumatologist finally identified the condition correctly. That delay is not acceptable. And it is largely preventable. Because Sjögren's shows itself. Not in a way that requires a laboratory or a specialist's office. It shows itself on your face. In your eyes, your mouth, your skin, the shape of your jaw, the surface of your tongue. Everything that follows is exactly what to look for, sign by sign, so that you can walk into your next medical appointment armed with the right observations, the right language, and the right questions. Hit subscribe and leave a like. That helps this channel reach more people who need it. The goal at Health Insight is 200,000 subscribers, and every single person who joins moves us closer. And if that sentence just landed for you, if something in what I've described so far sounds familiar, I've put together a symptom map that shows exactly how this condition progresses, what shows up at each stage, and where the standard tests are most likely to miss it. Type symptom map in the comments right now and I'll send you the link to access it directly. Number 1. Your eyes. Start here because the eyes are where Sjögren's most commonly and most visibly announces itself. Pull your lower eyelid gently downward with one finger and look at the inner lining. That tissue, called the palpebral conjunctiva, should be a healthy salmon pink and it should look visibly moist, almost glistening. If it looks pale, dry, slightly papery, or seems to drag a little as you pull it down, pay attention to that. It does not mean Sjögren's with certainty, but it means the tear environment inside that eye is not what it should be, and that is information worth acting on. Now look at the surface of the eyeball itself, not the lining but the actual exposed surface of the eye. A healthy eye looks bright, glossy, almost mirror-like, because a stable and continuous tear film is coating it. That tear film is made up of 3 layers, a mucin layer, a watery aqueous layer, and an outer lipid layer, and all 3 need to function correctly for the surface to remain comfortable and intact. In Sjögren's, the immune system generates chronic inflammation within the lacrimal glands, the glands that produce the watery aqueous component of the tear film. As that inflammation builds over time, the glandular tissue is progressively replaced by infiltrating immune cells, and tear secretion drops. The result is a tear film that either produces too little volume or breaks up across the eye surface far more quickly than it should. When you look at that eye and it looks dull rather than glossy, you are looking at a compromised tear film. This is called aqueous deficient dry eye, and it is one of the 2 cardinal features of Sjögren's, the other being dry mouth. It is present in the large majority of Sjögren's patients, and it is consistently documented in the peer-reviewed rheumatology and ophthalmology literature as among the earliest and most persistent presenting features of the disease. The problem is that dry eye is common for many reasons. Screen use, low humidity, contact lens wear, certain medications, and hormonal changes can all reduce tear production. So when someone with early Sjögren's complains of dry eyes, the instinct is to reach for artificial tears and move on. That instinct, repeated enough times across enough appointments, is responsible for years of diagnostic delay. What makes Sjögren's dry eye different is its character. It is persistent regardless of environment or season. It does not resolve meaningfully with standard over-the-counter eye drops. It may produce a paradoxical reflex tearing, meaning the eye waters excessively in response to wind, cold air, or light, because an unstable tear film triggers the reflex tear glands to compensate. And it is accompanied by a constellation of other symptoms that together form a recognizable pattern. The burning, the grittiness, the feeling that something is permanently caught in the eye, the sensitivity to light, the difficulty keeping the eyes open for extended reading or screen use, these are not separate small complaints. They are a single story about a tear-producing system under sustained immune attack. There is one more thing to check before you move away from the eyes. Look at the outer corners of your eyelids and at the eyelid margins themselves. Chronic ocular surface inflammation in Sjögren's can cause changes to the meibomian glands, which are the oil-producing glands that run along the edge of the eyelids. When those glands are affected, the lipid layer of the tear film is also compromised, and the eyelid margins may look slightly inflamed, thickened, or irregular. This is not always obvious to the naked eye without magnification, but if your eyelids regularly feel sore, sticky upon waking, or if you notice crusting or discharge at the lash line that is not explained by infection, add that to the picture you are building. If you have been dealing with chronic dry eyes and nobody has ever mentioned Sjögren's to you, type the word eyes in the comments right now. You will be surprised how many people watching this are in the exact same position. Number 2. The corners and inside of your mouth. Move now to your mouth. Start at the corners of your lips and look closely. Are they cracked, sore, tender when you open your mouth wide, or do they split and bleed in a way that refuses to fully heal regardless of how much lip balm or moisturizer you apply? This is called angular cheilitis, and it is a well-recognized clinical sign in conditions that reduce salivary flow. In Sjögren's it develops because the persistent reduction in saliva alters the microbial environment around the mouth. Saliva is not passive moisture. It contains antimicrobial proteins including lysozyme, lactoferrin, and immunoglobulin A, all of which actively regulate the balance of bacteria and fungi in and around the oral cavity. When salivary output drops, that regulatory system weakens, and the warm, slightly moist environment at the corners of the mouth becomes vulnerable to persistent candida overgrowth or bacterial involvement. No topical treatment addresses the underlying cause. It keeps coming back because the driver of the problem, reduced immune protection from reduced saliva, has not been addressed. Now open your mouth and look at the tissue on the inside of your cheeks, your gums, and the roof of your mouth. All of that tissue should look moist and slightly shiny. There should be visible wetness. If the tissue looks dull, matte, or slightly tacky, and if the inside of your mouth often feels like it is coated in a thin film or sticks slightly when your tongue moves across it, that is reduced salivary output making itself visible. Saliva performs functions that most people only appreciate when it is gone. It neutralizes the acid produced by oral bacteria after every meal, protecting enamel from demineralization. It provides minerals including calcium and phosphate that help remineralize early tooth surface damage before it progresses to decay. It lubricates food boluses so that chewing and swallowing are comfortable and safe. It helps initiate the chemical digestion of starches through the enzyme amylase. It maintains the pH balance of the oral cavity, and it provides continuous low-level antimicrobial protection. When Sjögren's progressively reduces salivary flow, every single one of those functions is compromised simultaneously, and the consequences accumulate across every structure in the mouth over months and years. The dry mouth of Sjögren's is not the same experience as waking up thirsty after not drinking enough water. It is persistent throughout the day and tends to worsen significantly at night when baseline salivary flow drops further. It makes eating dry foods, bread, crackers, meat, genuinely difficult without constant sips of water. It makes sustained speaking uncomfortable after a short while. It makes swallowing tablets harder than it should be. It can cause a burning or raw sensation across the entire mouth that people describe as having had something hot repeatedly. And it wakes people up in the night because the dryness becomes intolerable during sleep. These are not small inconveniences. They are measurable, progressive quality of life impairments that trace directly to an immune process that can be identified and managed. If you have been living with a persistently dry mouth and nobody has investigated the underlying cause, type the word mouth in the comments below. Number 3. Your teeth. Look at your teeth carefully. This is not a part of most people's daily mirror check, but it belongs on this list. Focus specifically on the gum line, the point where each tooth meets the gum tissue, and on the incisal edges, the biting surfaces of the front teeth. Sjögren's related dental decay has a distribution pattern that differs from ordinary decay. Ordinary decay tends to occur on the biting surfaces of back teeth and in the contact points between adjacent teeth where food gets trapped. Sjögren's related decay concentrates at the cervical margin, the gum line junction, and at the incisal edges of front teeth, because these are the surfaces most exposed to the acid environment that builds up when saliva is insufficient to neutralize it. This pattern of cervical and incisal decay progressing faster than hygiene habits or diet would predict has been documented in the Sjögren's literature for decades. It is one of the oral manifestations that oral medicine specialists and dental professionals with autoimmune awareness recognize as a red flag. Yet the majority of people with undiagnosed Sjögren's spend years receiving restorative dental treatment for what appears to be ordinary caries, without any clinician connecting the pattern to an underlying systemic cause. The decay is not the disease. The decay is a consequence of the disease. And until the disease is identified and salivary flow is supported and protected, the decay will continue regardless of how carefully the person brushes, flosses, or avoids sugar. If your dentist has ever expressed surprise at how quickly decay is progressing relative to your hygiene, or if you have had more fillings, crowns, or restorations than seems proportionate to the care you take of your teeth, that discrepancy is medically significant and worth raising with a rheumatologist. If you have had dental problems that do not match your hygiene habits and nobody has investigated why, type the word teeth in the comments right now. Number 4. Your tongue. Look at your tongue. It should have a clear, textured surface created by thousands of tiny projections called papillae, which cover the dorsal surface and give the tongue its characteristic slightly rough appearance. Those papillae contain taste buds and sensory nerve endings, and they are among the most rapidly renewing cell populations in the human body, turning over every 7 to 10 days under normal conditions. That rapid renewal means the tongue is exquisitely sensitive to nutritional insufficiency. When the building materials needed for that renewal are not available at adequate levels, the papillae begin to atrophy and the tongue surface loses its texture, becoming smooth, flat, and sometimes almost polished in appearance. This is called atrophic glossitis, and in Sjögren's it reflects the nutritional deficiencies, particularly low B12 and low iron, that are common secondary consequences of chronic autoimmune disease. But the tongue in Sjögren's carries more information than just nutritional status. Because reduced saliva means that the tongue is no longer bathed in the protective, lubricating, antimicrobial fluid it depends on, the tongue surface itself becomes vulnerable. Many Sjögren's patients describe a persistent burning or scalding sensation on the tongue that is often worse later in the day, and that no amount of water intake fully relieves. This is related partly to the dryness itself and partly to neuropathic changes that Sjögren's can drive in the small sensory nerve fibers supplying the oral mucosa. Small fiber neuropathy is a recognized and increasingly well-documented complication of Sjögren's, and the mouth and tongue are frequently among the first sites where that neuropathic process makes itself felt, often years before formal neurological testing identifies it. Now look specifically for any white coating on your tongue that is not the ordinary pale film present on most tongues first thing in the morning. Sjögren's associated oral thrush, which is overgrowth of the fungus Candida albicans, produces white patches or a thicker coating that may look slightly raised, may feel rough or tender when touched, and that does not simply wipe away with a dry cloth. It tends to recur. And recurrent oral thrush in a person not taking antibiotics or corticosteroid inhalers, not immunocompromised by a known cause, and not diabetic, is a clinical signal that should be investigated because it suggests a mucosal immune defense that is no longer functioning as it should. In Sjögren's, that immune defense failure traces directly to the loss of salivary antimicrobial proteins. If your tongue burns, feels persistently rough or sore, or looks unusually smooth, type the word tongue in the comments below. Number 5. The area in front of your ears and along your jaw. This is the check that people almost never do because most people do not think of the area in front of the ear and along the jaw as somewhere to look for disease. but it is one of the most diagnostically important areas of the face for Sjögren's. Place your fingertips just in front of each ear and press gently. Then trace down toward the angle of the jaw on both sides. Now feel along the underside of the jaw from the chin back toward the angle on each side. You are checking the locations of 4 of the major salivary glands. The parotid glands sit in front of and just below each ear, and they are the largest salivary glands in the body. The submandibular glands sit below the jaw roughly in the area between the chin and the angle of the jaw on each side. In Sjögren's, immune cells infiltrate the salivary glands in aggregates called lymphocytic foci. As this infiltration progresses over time, the glandular architecture is disrupted, normal secretory tissue is replaced by inflammatory cells, and the functional tissue that produces saliva is gradually destroyed. But before that destruction is complete, the immune infiltration itself can cause the gland to enlarge. Recurrent parotid gland swelling is reported in approximately 1/3 of patients with primary Sjögren's according to published clinical data. It typically presents as a soft, sometimes slightly firm fullness in front of the ear that comes and goes, sometimes correlating with meals, sometimes appearing without an obvious trigger and then resolving over days or weeks. It is usually painless or only mildly uncomfortable, which is precisely why it is so easily dismissed or attributed to weight change, dental issues, or simply the way someone's face is structured. Persistent or recurring parotid enlargement in the context of dry eyes and dry mouth is considered a classic clinical triad that rheumatologists and specialist clinicians look for specifically when Sjögren's is being considered. If you have ever noticed a fullness or swelling near your ears or jaw that nobody has explained, and you have also recognized symptoms from the previous sections of this video, that combination is important and it belongs in front of a specialist. It is also worth knowing that very rarely, long-standing lymphocytic infiltration of the salivary glands in Sjögren's carries a modestly elevated risk of developing into a form of lymphoma called mucosa-associated lymphoid tissue lymphoma, or MALT lymphoma. The absolute risk is low and should not cause alarm, but it is one of the reasons that persistent unexplained parotid swelling in a Sjögren's context is always taken seriously and monitored appropriately by a specialist team. This is not a reason to panic. It is a reason to be seen. If you have ever noticed unexplained swelling near your ears or jaw that comes and goes, type the word JW in the comments below. Number 6. Your skin and overall facial appearance. Step back now and look at your face as a whole. Not at specific features but at the overall picture. Has your face changed in the past year or two in ways that are gradual and difficult to describe precisely? Has your skin become drier than it used to be, not seasonally but consistently across the year? Does your face look more tired or worn than your age or your lifestyle accounts for? Does your skin feel tight, or do you experience an itching sensation across the face or body that is not accompanied by an obvious rash? Sjögren's affects the skin through several mechanisms. The exocrine glands in the skin, the same category of gland as the lacrimal and salivary glands, can be subject to the same immune-mediated damage, reducing the skin's natural secretory functions and its ability to maintain adequate surface hydration. Beyond the glandular mechanism, the systemic inflammatory burden of Sjögren's can impair skin barrier function and alter the cellular environment in the dermis in ways that produce a persistently dry, sometimes sensitive skin picture that standard moisturizers address only superficially. Some Sjögren's patients develop a specific skin manifestation called annular erythema, which produces ring-shaped or arc-shaped areas of redness, most commonly on the face and upper trunk. These patches tend to come and go. They are often flat rather than raised, and they are frequently misidentified as eczema, seborrheic dermatitis, rosacea, or a fungal infection. Annular erythema is more commonly reported in patients of East Asian background, but is not confined to any single ethnicity. It is not present in all Sjögren's patients, but when it is present alongside other signs discussed in this video, it strengthens the clinical picture considerably. It is also worth stepping back to look at the overall color and tone of your skin in this context. Sjögren's is associated with a higher rate of Raynaud's phenomenon, a condition in which the small blood vessels in the fingers, toes, and sometimes the face overreact to cold or emotional stress, temporarily reducing blood flow and causing the affected area to turn white, then blue, then red as circulation returns. If you have ever noticed your fingers or the tip of your nose turning distinctly pale or bluish in the cold when other people around you aren't affected, and you have recognized other signs from this video, that is relevant clinical information. There is something else worth considering when you look at your face as a whole. Sjögren's has recognized overlap with several other autoimmune conditions. Approximately 30% of people with primary Sjögren's also have features of another autoimmune disease, most commonly rheumatoid arthritis, systemic lupus erythematosus, thyroid autoimmune disease, or primary biliary cholangitis. If you already carry a diagnosis of one of those conditions and the signs you have just checked feel familiar, it is genuinely possible that what you are looking at is an overlap syndrome that has not yet been identified or addressed. Overlap syndromes are not rare exceptions in autoimmunity. They are common, and they matter because the management of Sjögren's in combination with another autoimmune condition requires a coordinated approach that a single diagnosis alone does not capture. If your skin has been persistently dry, or your face has changed in ways that you cannot fully explain, type the word skin in the comments below. Number 7. Putting the whole picture together. There is something important to understand about every sign you have just checked. None of them in isolation is diagnostic of Sjögren's. Dry eyes have many causes. Angular cheilitis has many causes. A smooth tongue can reflect dietary deficiency without any autoimmune involvement. Salivary gland swelling can occur with infection, with certain medications, and with other medical conditions. The power of what you have just done is not in any single finding. It is in the pattern. The diagnostic criteria currently used for Sjögren's, including the two most widely referenced classification systems, the American College of Rheumatology and European League Against Rheumatism criteria revised in 2016, incorporate a combination of subjective symptoms, objective clinical tests, laboratory findings, and biopsy results to establish a diagnosis. The process typically involves a lip biopsy to look for lymphocytic infiltration of the minor salivary glands, blood tests for specific autoantibodies called anti-SSA and anti-SSB antibodies, a Schummer test to measure tear production, and a test called unstimulated whole saliva flow to measure salivary output. Not every patient has all features and not every test is positive in every case. What that means practically is this. You cannot diagnose yourself from a mirror. But you can recognize a pattern. And that pattern, observed and articulated clearly, is what gets a referral to a rheumatologist moving. It is what changes a 5-year diagnostic journey into a 6-month one. The people who get diagnosed quickly are not the lucky ones. They are the ones who came to their appointment with a clear, organized account of what they had been experiencing and for how long. They connected the dry eyes to the dry mouth to the dental changes to the jaw swelling to the fatigue to the joint pain, and they said all of it in the same appointment. That connected picture is what a rheumatologist is listening for. And now you know how to build it. The symptom map linked below this video was built for exactly this purpose. It gives you a structured framework for documenting what you have been experiencing, when it started, how it has changed, and how it connects, so that when you sit down with a doctor you are not starting from scratch, repeating a fragmented history, and hoping that the right question gets asked. You are presenting a complete picture from the first minute. Download it before your next appointment. Because what you have looked at today is the face. And the face is just the beginning. Sjögren's is a systemic disease. What is happening inside, in the joints, the peripheral nerves, the kidneys, the lungs, the blood, and the cardiovascular system, often quietly and over years, is what the next video covers. It is right here. Go watch it now.